Instagram, you're online on Facebook, and you're online on YouTube.
Hi everybody, Dr. Rahi Victory here. Welcome to Fertility Fact or Fiction, where we discuss all of the newest evidence or pertinent topics for you guys, try and bring out the truth in all of the subjects that we talk about, make sure we are providing you with the most up-to-date information to help you on your journey and to get you through your particular path with hopefully the least amount of effort, the least amount of cost, and the best outcome possible. So we are super excited to have you guys with us. We are going to be discussing an interesting topic tonight, which is all about fibroids. And this came about because a lot of patients keep asking us to review fibroids, and they want to know about how fibroids impact fertility, what they are, should you have them removed or should you not have them removed? When is it important to take care of them? When is it not important to take care of them? So I thought rather than review a study, tonight we would just review fibroids in general and talk about those. So as usual, we always ask for you guys to grab something to eat or drink and settle in, and we'll get into it and talk about all the different things that you can do in regards to fibroids. And hopefully you guys have all had a good week. With some luck, most of us have all been at least initially vaccinated. I read a really great article with my amazing wife last night stating that the idea behind the single dose of the vaccine in Canada being just one dose and then now 4 months later you're getting your next dose is actually a good thing, because the fact that they chose the 3-week interval for the second dose was completely arbitrary and actually not founded in any kind of science whatsoever. And when you look at other vaccines, like the hepatitis vaccines or the HPV vaccines, there's about a 2-month interval or even up to a 6-month interval. So they're actually saying that we can spread it out over time and still probably get a very good yield from the COVID vaccination. So hopefully that'll work for all of us, get more of us vaccinated, keep more of us safe. And with a lot of luck, it's also convinced my wife to let us bring her daughter back home from overseas because she didn't want her coming back until she'd been vaccinated. So hopefully we're in the first steps of getting everybody vaccinated. If you have not gotten your vaccine yet, please try. If you are eligible, if you are pregnant and you're wondering if it's safe, it is safe. It is no different than actually acquiring COVID, which, with the exception of the actual infection having a tendency to cause problems with preterm delivery or the babies being a bit smaller, if you're really aggressively infected, there are no side effects from COVID infection, and therefore there are even fewer side effects from COVID vaccination. So get vaccinated if you can. Okay, so we're going to talk about fibroids. So the reason this is a particular area of interest for me is that when I was doing my fellowship in infertility, my instructor, the amazing Dr. Michael Diamond, came to me and said, I want you to write a chapter for a textbook. Now, obviously, I'd never written a chapter for a textbook before. Daunting task. I had to spend about 6 months just reading and researching for this, reviewed 262 articles, and then wrote about 100 pages for this textbook, all of which had to be compiled into this, compressed format after they asked us for revisions and edits and so on. So it was kind of an A to Z on everything related to fibroids. And so I wanted to share some of that knowledge with you guys because I've stayed abreast of that knowledge and stayed on top of it, and we can go over all of the different elements of what we do and how we do it and so on. And I think, unfortunately, there's a lot of misinformation out there about fibroids. And people think that they're not necessarily in need of treatment, but frequently you actually could be. So let's just start with what fibroids are. Fibroids are benign, smooth muscle tumors of the uterus that are very, very common. So what does that mean in English? It's basically a very firm rubber ball stuck in the middle of your uterus that are very common in a lot of women. They do not cause cancer. They don't become cancerous. There is a version of the fibroid that is malignant called a leiomyosarcoma, but it's present in a very, very small number of women, and it tends to have differences in the way it looks and certainly in the way it behaves. So they should be reasonably distinguished from normal fibroids, but not always, and we can be fooled at times. So with the fibroids, these benign tumors of the uterus, what happens is one single muscle cell from the wall of the uterus becomes a sort of abnormally growing tumor-like process, and it just keeps multiplying and multiplying until it turns into this sort of ball of cells. It's the same type of cell that the uterine muscle is made out of, but because it's just one, it can actually distinguish itself, and they're very compressed and firm, often very solid. You can have tiny, tiny little ones, or you can have great big huge ones. They come in all sorts of different shapes and sizes. Sometimes the fibroid has other little lumps and bumps growing off of it. Sometimes it's perfectly round, sometimes they're not. It all depends on where it's located. The location is very interesting as well. So you can have fibroids that are located inside the cavity of the uterus. We call those submucosal. I'm hoping Tara can pull up a picture while we're talking, but I don't know if you can do that or not. So we have the ones that are inside the cavity of the uterus. This is where your endometrium is, which sheds every month with your period. This is where the baby grows, and so on. You can have them in the wall of the uterus. So that part is called intramural, mural being the Latin word for wall, and so it's intramural, meaning in the wall. You can have them just under the outer surface of the uterus, and that's called subserosal, or you can have them where they are kind of dangling off the outside of the uterus, and those are often called pedunculated. There are mixtures of them where it can be kind of halfway in the cavity, halfway in the wall, or halfway out of the uterus and halfway in the wall, and so on. Or you may actually have ones that detach from the uterus and implant in other places, and they can get their blood supply from there. They usually start off as the pedunculated version. It detaches early on by sticking to the bladder or the abdominal wall or so on. So those are pretty rare, but we do see them every once in a while. Depending on where the fibroid is located and how big it is, it can actually impact your fertility. So if they're pedunculated and they're just sticking off the outside of the uterus, there is generally no impact on your fertility whatsoever, unless it's really pressing on a fallopian tube or the ovary, which is extremely uncommon. I've actually never seen one do that before, although I'm sure it could. If it's under the sort of outer surface of the uterus, the ones we call subserosal, those also generally do not cause any problems in terms of fertility, unless again it's in an awkward location where it's pressing on a fallopian tube or obstructing a fallopian tube. And certainly in those locations, it is possible that it's a problem. The inner part where it's in the wall can be a problem if it's very large, and because it's very large, it is pushing on the inside of the uterus. And there are studies that have shown that if it is larger than 4 centimeters in the wall of the uterus, it is big enough to be causing a problem with fertility. The ones that are inside the uterus, or even partially inside the cavity of the uterus, the submucosal ones, those ones definitely in almost every study have been shown to decrease your implantation rates and increase your rates of miscarriage quite significantly, so that the implantation is usually reduced anywhere from about 50 to 70%, and the miscarriage rate is generally doubled. So it is commonly accepted that if the fibroid is in the cavity of the uterus, you need to have those removed, or if it is very large in the wall of the uterus and causing like an indentation inside the cavity of the uterus, you need to also have those removed. Now, why is this not traditionally done? Well, it's not always done because a lot of fertility specialists don't like the idea of operating on you because they're not doing the surgery themselves. That means they have to send you to someone else. You may decide to move to a different center. They feel like they're losing your business, and rather than lose your business, they want to kind of keep you, so they want to jump into treatment. Number 2, patients don't love it when they have to delay, and some fibroid surgeries, especially the ones where we've got to go into the wall of the uterus, require minimum of months of delay for your uterus to heal properly before you can get pregnant again. And so people don't necessarily like that. And again, the physicians are worried that patients are going to go somewhere else where they're not being told to remove the fibroids. And the third problem, of course, is that the surgery is not easy. Not everybody knows how to do it, and it can cause damage to your structures, including the uterus. So when I was doing my research for this chapter, there were studies that said that up to 6% of patients who are undergoing a myomectomy, which is the name of the surgery we do when we're removing a fibroid, can actually end up with a hysterectomy. Now, I've had to do a hysterectomy twice in my career for doing myomectomies. One was on a woman who had over 50 fibroids in her uterus, and there was no way to salvage the uterus. It was impossible. I didn't actually have to do the hysterectomy, but she wanted her fibroids dealt with. I could not salvage the uterus because the fibroids were so bad, and so we just ended up doing the hysterectomy on her instead. The other was actually in a almost 70-year-old lady who had a giant fibroid inside the cavity of her uterus, and it didn't make sense in a 70-year-old to try and just resect the fibroid, so we actually removed the uterus. So in general, the rate is quoted at 6%, but I'd probably say it's a fraction of 1% in the right hands, where we are going in knowing what we're doing and we're being careful about it. So how do you diagnose these fibroids? So diagnosis is history, physical examination. Sometimes you can feel them, especially if they're very large, and you can diagnose them with either transvaginal or even transabdominal ultrasound. In certain circumstances, we'll do an MRI so that you can figure out exactly where the fibroids are, what the relationship is to the blood supply. Is it, in the ovary, near the fallopian tube, and so on. So these are the things that MRI can sometimes distinguish for us. Once you've diagnosed it, the question then becomes also, what are the symptoms? So in most women, they'll have no symptoms if they're very small. Common symptoms are heavy bleeding, pressure, pain, spotting if it's inside the cavity of the uterus. That's very common. You can have problems with pressure on other organs. So it can press on your bladder, make you pee more frequently. It can press on your bowel, make it more difficult or feel like you have to strain to have a bowel movement. And certainly some of them can cause pain, especially if some of the weirder things happen, like they begin to degenerate in the center of the fibroid, because if they outgrow their blood supply, the middle of the fibroid can have almost like a fibroid heart attack. It dies, and when it starts to cavitate, it can cause a lot of pain and discomfort. You can also get infected fibroids from that same type of process. If it's inside the cavity of the uterus, there are some women that will actually deliver the fibroid just like they're delivering a baby. That's called a prolapsed fibroid. It's actually fairly dangerous because they get infected and it's still attached, and those patients can become septic very, very quickly. So those are some of the sort of more common complications we might see in various types of fibroids. You can have degeneration, pain, and so on. If you're pregnant and you've got fibroids, there's a very well-known phenomenon where the fibroid outgrows its blood supply, the center of it dies. It's called red degeneration, and that can cause quite significant pain during the pregnancy, sometimes some spotting and bleeding, and it can really be debilitating. So hospitalization is often necessary for that kind of process. Okay, so we know what symptoms you might have. We know what kind of diagnostic tools we're going to use. How do we treat them? So if they're small, they're not in the way, they're not bothering you, you don't have symptoms, you don't need to do anything for your fibroids. You can leave them alone. What will happen to them? Most of them will continue to grow as long as you are in your reproductive years and supplying your fibroid with estrogen and progesterone, which makes them grow. Now, they might grow a little bit, they might grow a lot. There's no way to predict that, but they do grow. And certainly there are risk factors. So if you are Black, you're at a much higher risk of having fibroids. If you are Asian, you're at a higher risk of having fibroids. Hispanic has a higher risk of having fibroids. So all of these things can contribute to the chances that you have more fibroids or fibroid growth. But you can do nothing, and that's perfectly legitimate. If you actually want something done and you just need symptom control, you're not looking for control of fertility, something simple like birth control pill or the Mirena IUD can work, Depo-Provera can work. So any of these can control the bleeding pattern, sometimes alleviate the pain. It's not going to stop the fibroid from growing, but it can help you with the symptoms of pain and bleeding and so on. If you're looking for something that will shrink the fibroid, or you want sort of more aggressive treatment so that you can proceed with fertility, there are medical treatments, there are sort of minimally invasive treatments, and then there are surgical options. So let's talk about the medical ones first. So we know that a GnRH agonist can reduce the size of the fibroid. So a product like Lupron, or if you're using the oral ones now, Orilissa, these can shrink fibroids. It shrinks it 50% by volume. And the important thing to remember there is that it doesn't mean a 5 centimeter diameter fibroid becomes a 2.5 centimeter diameter. The equation for the volume of a sphere, because they're roughly spherical, is 4/3 pi r cubed, which means a 5 centimeter fibroid probably becomes, I'm guessing here, about a 3.8 centimeter fibroid. So it's not going to be that much smaller, but volumetrically it is actually 50% reduction. But in diameter, it's going to still be fairly large. So those work very, very well. It will shrink. Once you stop the GnRH agonist, it will re-expand and regrow. You're not killing the fibroid, you're shrinking it. It will come back again. Side effects, all of the side effects of menopause, so hot flashes, night sweats, mood swings, vaginal dryness, sleep disturbance, decreased sex drive. And if you believe people online, including the Lupron victims group, who I am in communication with, they swear that it has huge side effects and that nobody should be on it. So we don't have data for that yet, but there are a lot of people out there who have taken Lupron and had very negative side effects from it. You can then try taking something like as I mentioned earlier, the Orilissa. That's a possibility. And for some time, we had a fantastic product called called Fibristol. And Fibristol was part of a class of drugs called Sperms, which stands for Selective Progesterone Receptor Modulator. These actually were able to kill the fibroid cells and permanently shrink them about 50%. But some women, especially in Europe, were starting to get very severe liver disease in response to taking this medication. So they stopped production and use. It is a shame because overall it had a great profile and it was very, very, very few people who actually ended up with any kind of liver disease or problem, but they were significant enough that they pulled it from the market. So those are no longer available. A shame in some ways, but obviously protecting people is job number one. So those are really the medical options for shrinking a fibroid. There isn't actually anything else that will shrink it. It's either the GnRH antagonist like Orilissa, there is the GnRH agonist like Lupron or Superfact or any of these. Triptorelin is another one, or you are looking at doing the medications that are unfortunately no longer available, at least here in Canada. And it was never available in the US, so it won't be available there either, guys. The next stage is the minimally invasive treatments. So there are a couple of different approaches to this. There are some devices that have been designed for laparoscopic treatment. One is called HALT or Accessa. I don't know if it's still in production. It was super complicated to use. We were going to be one of the sites that did it. They backed out of the study at the last minute. It was very, very complicated technology. I'm not even really sure it was worth it. So that was one approach to it. There is ultrasound or MRI guided high frequency ultrasound, or HIFU as they like to call it. So that can kind of kill the fibroid. It turns it into more of a jelly consistency. It does shrink them a little bit, but you're not actually removing the fibroid. So if it's very big and it's deflecting the inside of the cavity, you may or may not get the result that you want from doing something like that. The advantage is it's non-surgical, but it doesn't always work for what we want it to do. Next option is to do either a uterine fibroid embolization or a uterine artery embolization. So with this, you're actually either selectively blocking the blood supply to the fibroid, or you are blocking the entire blood supply to the uterus. So blocking the blood supply to the fibroid can work quite well. You get, again, about a 50% volume shrinkage, and it tends to have one significant side effect, which is awe-inspiring pain, but it will dissipate after a while, and otherwise there are not a lot of problems from it. Depending on the location of the fibroid, it may or may not be okay to do. You mainly are doing them for the ones that are in the wall or just under the outer surface. If it's pedunculated, you cannot. If it's predominantly outside of the wall, you cannot. And it can cause a lot of inflammation, which can then cause adhesion. So these are some of the things we worry about when we're doing this. If you want to do uterine artery embolization, let's say you're chock full of fibroids, that has very significant negative effects on pregnancy. No one who is interested in pursuing pregnancy should do a uterine artery embolization. It can, in women over the age of 35, also significantly decrease your ovarian reserve, because the particles that they use to block your uterine arteries can actually float up into your ovarian blood supply and block the ovarian blood supply. So not a good idea for some women, reasonable in others, but only if you're not trying to get pregnant. The final options are surgical. So if it's inside the cavity of the uterus, or mostly inside the cavity of the uterus, a carefully done hysteroscopic, meaning camera in the uterus approach, is 100% reasonable and extremely effective, simple. You just have to have a good surgeon, because it is very common to perforate the uterus if you don't know what you're doing. So a million years ago, when I went to a US-based conference, they had this great laparoscopic hysteroscopic trainer where you could sit down, and they had this kind of video screen. And it was like a video game, and they were testing people who were resecting their fibroid in the cavity of the uterus on the computer screen, and person after person perforated the uterus, which essentially could kill the patient if it's a bad enough perforation. So you do need someone that's good and knows what they're doing. It is very easy to not perforate. You just have to know what you're doing when you're doing these. So it's quite safe in the right hands. Make sure your surgeon has loads of experience before you do it with them. If it's in the wall of the uterus, or more on the outside, you're going to need more major surgeries. So those ones either require a laparoscopic approach or an open approach. In the laparoscopic setting, we used to do it all the time. The problem is you needed a morcellator, a device that can chew up the fibroid. And some lunatic in the US chewed up a fibroid, which actually wasn't a fibroid, it was a cancer, during a hysterectomy case, and they spread the cancer all over the place. It happened to be the wife of a Harvard physician, and the patient themselves was a physician as well. And they went absolutely nuclear and stopped production of the morcellator, which allowed us to chew up the fibroid. So laparoscopic myomectomies are a lot harder now. Our hospital no longer has the morcellators, and they won't bring them in for us either. So it's a lot tougher to get the laparoscopic approaches done. It's also much harder to stitch the uterus properly laparoscopically. It is the one and only instance in which I would advocate for having a robot. Most of the time I don't need a robot to do any of my laparoscopic procedures, but for that one instance you kind of need them. And then finally, you can do an open procedure. I do mine through a mini laparotomy, usually just 4 to 6 centimeters. So they're a very, very tiny incision. I can get virtually any fibroid out through there. And that allows me to do a proper closure of the wounds where I don't need to worry. Why is the closure important? Because you're going to take this uterus that you've just put an incision on, and you're going to put it under tension as the uterus grows. If you don't close the wound well enough, it can pull apart. You now have a uterine rupture, and that's an unholy disaster for you and the baby. When you remove a fibroid, it's kind of got like a crater effect where you leave a hole in the uterus. So the key to proper closure is to do it in layers. You need to close it up layer by layer by layer by layer by layer. So if I have even something like a 3 or a 4 centimeter fibroid, I'm probably putting in 3, 4, sometimes up to 8 layers in the larger fibroids of stitch just to make sure I've completely closed that space. And then you have to close the surface of it very well as well with a special type of stitching procedure called a baseball suture. So all of these are the techniques we use to do a very good myomectomy. In the right hands, when you've had a good myomectomy, if you go to a surgeon, they will not even be able to tell, or sorry, not a surgeon, an REI, they should not be able to tell on ultrasound that you've had the myomectomy. There should be no problems there. So those are your various options. So can it impact fertility? Absolutely it can. You can get decreased implantation, increased miscarriage rates with natural and with IVF procedures. Should you have them removed? Yes, if they're in the wrong place or they're big and they're deflecting the uterus, you should have them removed prior to doing your IVF because you're wasting good embryos otherwise. Does everybody need to have them removed? No, it depends on the size and the location, but in certain circumstances it is definitely indicated. How do you get them removed? Or shrunken, it depends on each patient. For shrinking them, there are certain medications. You need to talk to your doctor about that to see if you're eligible for that. You can try the minimally invasive techniques, or you have the surgeries to try and actually remove the fibroids. One final quick note, if you do have lots of fibroids and you remove them, there is a 30% 5-year recurrence. So you do have a window of opportunity within which to try and get pregnant. Otherwise, you can run into complications with recurrence. So thank you for listening into that. I hope that did help you guys out. We'll post this on our YouTube channel and call it Fibroids and Fertility. And hopefully it'll give you guys some information you need to make a good decision for you. So we're going to take your questions now, and I'm going to stop yapping at 100 miles an hour.
All right. First question. If we have multiple fibroids outside of our uterus, should I go for IUI, doctor, remove polyp in December? Any risk for pregnancy?
Yeah, so if it's outside the uterus, as long as it's not pushing on your tubes, you shouldn't have any problems. You may get some pain or pressure during the pregnancy, but there's no reason you can't try for an IUI as long as it's not blocking your fallopian tubes. And a well done ultrasound, especially the 3D ones that we do, or an MRI should be able to answer that for you.
So I want to answer all the fibroid related questions
Yeah,
first.
sure. Great.
Okay. Okay. Is a polyp more risky than a fibroid for fertility?
No, anything in the cavity has roughly the same effect. It's a lot easier to remove a polyp because the base tends to just be attached to the endometrium, and polyps are never embedded in the wall of the uterus or even in the lining of the uterus. They're attached, but they're not embedded. A fibroid can actually be embedded into the wall of the uterus and require literally kind of digging it out of there with the surgical instruments or shaving it out of there with the surgical instruments. So a polyp's much easier to deal with than a fibroid is.
Can fibroids ever go away on their own?
Not theoretically, unless it dies because it's not getting an adequate blood supply. And even then, usually you'll still have some remnant of it.
I'm 39 years old, multiple fibroids outside of the uterus. Doctor told me for IUI, should I need surgery first? If not, what's possible? What's the possibility to conceive? If I conceive, are there any risks?
So I think that's probably the same questioner as before. There are no significant risks aside from pain. You can try IUI. IUI at 39 is a whole other issue because it doesn't have a high success rate. But as long as that's what you want to try, there's no reason you can't try as long as they're outside the cavity of the uterus.
Would multiple fibroids make it harder for sperm to reach the fallopian tubes?
Only if they're blocking the fallopian tubes. So no, not necessarily.
Would you do IVF with 2 4-centimeter intramural fibroids?
Would I do your egg retrieval? Yes. Would I do your embryo transfer? Maybe. It depends on how many embryos you ended up with and how averse you were to having surgery. It also depends on the location of the fibroid. So if it is causing an indentation inside the cavity and 4 centimeters is where they actually recommend surgery, then yes, I would definitely want to take them out first. If they're more on the outside and the intramural component is not pushing onto the inside of the uterus, you might get away with success. Keep in mind, during the pregnancy, it can cause pain. Typically, if I had 2 4-centimeter fibroids, I would be having a long talk with you about removal, because I would likely be in favor of removal rather than going ahead with the IVF first. And again, it depends on how many embryos you have. If you have 10 embryos, you want to try once, that's totally reasonable, even twice. But if you have 2 embryos, you want everything perfect. Would I go ahead and do the surgery first? Of course, because I don't want you to find out after 1 embryo is gone, or God forbid both embryos are gone, oh, I should have taken out my fibroid. Now you need a whole new cycle of IVF. That's not fair to you. It's not fair to your embryos. It's definitely not fair to your bank book. So we're pretty cautious and careful about that.
Do fibroids cause irregular periods?
They can cause bleeding and spotting that's out of the norm. So yes. Yeah. Now, it doesn't cause irregular periods per se. You're not going to have a full bleed each time, but you can get spotting and abnormal bleeding when you have fibroids for sure. Yep.
I think that's all the
fibroid questions.
Yeah.
That went down the wrong hole. Okay. Fire away.
Oh, one more.
One more?
How long after uterine fibroid embolization can you try to conceive?
After an embolization, I'd probably wait a minimum of 3 months. And that's to allow the inflammation to settle down. You don't want to try and get pregnant when there's a lot of inflammation. So I'd say minimum 3 months. Yeah.
Okay. Fertility questions now.
Fertility questions. Bring it on.
All right, here we go. In PCOS, can the ovaries return to normal cyst-free?
So PCOS does not have cysts. Remember that. It's a terrible name for the disease. Polycystic ovarian syndrome has nothing to do with cysts. The cysts that they're describing were very little eggs that dot all around usually the outer kind of part of the ovary. So can someone with PCOS go back to normal? On ultrasound, it'll likely look similar, but you can get regular if you do all of the normal things that you need to, or take the medications that will get you regular. So you can go back to normal, but remember, PCOS does not cause cysts. It just causes irregular periods and a small cyst-looking appearance to your ovary, but they're not big cysts like 3 centimeters, 4 centimeters. They're like small, 7 millimeters, 8 millimeters, 3 millimeters, 4 millimeters, that kind of thing.
Pregnol was prescribed to my husband. Is diarrhea a normal side effect after his injections? Should we be concerned or call the office?
It's not normal, so you don't need to be concerned, but definitely call the office. He may be allergic or sensitive to something that's in it. And we have to do other tests to make sure he doesn't have an intestinal bug. Yeah.
At 43 AMH, 1 FSH 5, Gonal F300, Menopur 150, Letrozole 2.5, Ganorex 250, Ovidrol 250, and birth control. Optimal protocol and suggestions.
I think we had this question last time too. So, okay, that's a good protocol. I don't have any trouble with that. I don't necessarily think you should be on birth control. So birth control will likely suppress you. So I would probably eliminate the birth control because that part doesn't make sense in a patient that's 43. All of that medication is great, and I kind of support that approach to things. I would prepare yourself for either needing duostim or doing natural cycle, because depending on whether your AMH is in nanograms per mil or picomoles per liter, you may not produce that many eggs. If it's nanograms per mil, you're probably going to make a reasonable number and have a decent chance. If it's picomoles per liter, that's a very low AMH. You may only make 1 or 2 eggs, in which case you're taking a ton of medication for very, very little benefit, because you could actually do 2 natural cycle IVF cycles with almost no shots, no stress, and no medication, and actually do great. We just did an IVF cycle for a patient with very low AMH on the weekend. We did a natural cycle IVF cycle for her only gave her a smidgen of medication throughout the process, and we actually ended up getting 3 eggs from her. All 3 were mature. So it worked out great. We fertilized all 3. We'll see how we do. So you don't necessarily need to get pounded full of medication in order to get eggs. Sometimes it's easier and actually better to get less medication and do it more frequently. And it actually will end up being the same cost for you ultimately as well.
Hello, my husband has abnormal sperm morphology. Does this cause infertility in men? If so, is there still a chance I'm able to get pregnant? Thank you.
So it does. If you have very low sperm morphology, which if you're using this, it's called the strict criteria is 4% according to the World Health Organization, then you will have compromised fertility. So there are ways to fix that. In many instances, not in all. So vitamin intake, avoiding everything bad, smoking, drinking, drug use, including marijuana, keeping the testicles cool, healthy diet, weight loss for men, avoiding things like tight underwear or tight pants and so on, and avoiding heat, so hot tub saunas, jacuzzis. All of these things can really contribute to a much, much improved sperm performance, and you might see the morphology improve significantly. You also want them to ejaculate every 2 days. That can help as well. So yes, it could compromise your fertility or his fertility in this case, but there are ways to correct it. It's just a matter of taking those necessary steps.
Would multiple fibroids make it harder for sperm to reach the fallopian tubes?
They asked us that already.
Oh, they asked us that? Okay.
Yeah, it might, but only if they're blocking the tube, so to speak. So usually no. Yeah.
What are your thoughts on Matris? Do you recommend this?
Matris?
Yeah.
So Matris is an ultrasound technology that allows you to supposedly or hypothetically determine if the lining of the uterus is optimized for implantation of an embryo. There are some people in Toronto that are using it and claiming extremely good success rates from it. And we are about to try it in the next 20 frozen embryo transfers that we do. So I'm going to try it and I'll let you know after I see what the results are. Our success rates already are incredibly, incredibly high because of the wizardry of our amazing embryologist, Dr. Khosravi. We just hired another embryologist because we are so busy that we needed 2 and likely we need 3 very soon. So if you're a good embryologist and you're out there and interested in working with our amazing team, let us know. But we likely, I don't know if we're going to see that much of a difference because we're getting about 80% success right now overall. And if it, it takes you from being like 30% to 50, you're going to see a difference. But to get from 80 to 90 or 95 or something like that, it's going to be pretty tough to do that. So I don't know how much it'll improve our success, but hey, if it works, it's actually not very expensive. It's completely non-invasive, and it's harmless to the patients, aside from the fact that they will tell you not to transfer if you don't look good, and there's no way to correct it in time. So it might cancel cycles that you were ready for, which obviously emotionally can be quite burdensome. So we'll see. I'll let you guys know in probably about 2 months from now when we get the results back from the people we do in the next batch of frozen embryo transfers.
Is metformin the only medication for PCOS?
No. So PCOS treatment, and if you watch any of our Fact or Fiction shows, we talk about every show. So PCOS must have 3 approaches. And this is what so many people miss. People, doctors, patients, everybody misses this, okay? So there are 3 very critical elements to PCOS. Number one, you must be on medication, and the medications are going to be metformin and letrozole, or metformin and clomiphene. Letrozole is first line because it's been proven to be better than Clomid. Letrozole has a 27.5% success rate over 6 months, and Clomid had a 19.1. So letrozole is better in terms of live birth rate than Clomid is. So typically it's metformin, and metformin only if you're either insulin resistant or in the PCOS group that is non-thin, so they're carrying a little bit of extra weight. So that's good, that combination of medicines. The second part to PCOS, so that's what I call the medical part of it. The second part is the natural part. So the natural part is inositol, NAC or N-acetylcysteine, and coenzyme Q10. All three of those have proven clinical benefit in scientifically well done studies demonstrating that it'll improve your symptoms and the function of your ovaries. Nothing that's shown live birth, but it does improve the PCOS overall. And we've had tremendous success with this, so we use it for everybody now. It's like a cocktail for us. We have coenzyme Q10, the NAC, and the inositol. Everybody goes on that. The third part, which is actually the most important part, but only applies to the patients with the heavier side of PCOS, not the thin PCOS, which is about 10%, 90% struggle with their weight. So in that 90%, you must eat healthy, which means 1,500 calories per day or less, and you must exercise. And there is no way to correct the PCOS without the diet and the exercise, because it won't work. I can give you all the meds, I can give you everything, but if you don't get the weight down, you will remain in that high risk state forever. And it is high risk. You're at higher risk for cancer, you're at higher risk for heart disease, you're at higher risk for diabetes, depression, anxiety, all sorts of complications. So it is critical to deal with the global issues surrounding PCOS holistically, rather than just telling people just go lose weight. That's a dumb way to practice medicine, and I see that all the time. People go to the fertility specialist and they're told just go lose weight. That's ridiculous. We never tell anyone to just go lose weight. It's a critical and important part of the process, but it's a process. You need medical therapy, you need natural therapy, and you need the lifestyle changes. The three together will almost always result in a positive outcome for you.
Do you have any advice on how to have confidence in a pregnancy between week 13 and week 20 ultrasounds if you had a recurrent pregnancy loss? If pregnancy symptoms such as fetal movement or shoring are minimal in between those times?
Go to your fertility specialist or your OBGYN. Say, I have a history of recurrent pregnancy loss, and they should be able to ultrasound you. I never recommend this, but you may be the sole exception. If you're willing to learn how to do it properly, you could consider buying your own Doptone. That's the device that we use to check for the heartbeat, and look for the heartbeat yourself. It is complicated because, especially early on, like 13 weeks, it's very difficult to find. You have to be very good at it. And so if you don't find it, it's going to send you into an all-out panic mode, which we don't want. So I don't normally recommend it, but if you're really, sort of undergoing a lot of anxiety and stress over this, and you can't get your doctor to do the ultrasounds, then for sure I would probably tell you to get the Doptone and use that. And you would require some training. And then you actually need the backup of having a doctor that is going to be there for you when you find that you can't find the heartbeat and you're now extra panicked because you're wondering what happened. So if you don't have that, don't do it, because it'll actually just make you more anxious and more worried.
I have 4 fibroid questions, all a derivative or so different.
Okay.
Slight differences.
All right.
Do it like a rapid fire thing.
Okay, fire away.
So fibroids cause any problems with baby and pregnancy. Fibroids can affect ovulation, birth control, decrease symptoms of fibroid. Yeah, that's it.
Okay, so 3. So can it cause problems with pregnancy? It can cause problems with pregnancy If you get pain or they degenerate, so it'll cause some bleeding, spotting, pain. It can cause trouble at delivery. If they're big enough or in the wrong place, you can actually block a vaginal delivery or cause bleeding at delivery. It can never interfere with your ovulation, so there's not a fibroid in the universe that will interfere with your ovulation. And the last one was, does birth control decrease the symptoms? Birth control is actually very effective at decreasing the symptoms of bleeding and pain from fibroids, but it will not shrink or prevent the growth of your fibroid. So that's really important to know. Was that rapid fire enough?
Yeah, that was good. That was
good?
Absolutely, yeah, good job.
I got 2 thumbs up from Tarek on that one, guys.
So here's a question.
Okay.
What's the difference between polyps and fibroids, and do you need to have polyps removed before embryo transfer? And how long should you wait for an embryo transfer after having polyps removed?
Okay, so a polyp is an outgrowth from the inside of the lining of the uterus. It's generally endometrial in origin. A fibroid is from the wall of the uterus, so it's a layer deeper in, and it's attached to the wall of the uterus in one form or another. There is a very different pathophysiology behind them. The cell type is different. Everything about it is actually quite different. They may behave the same in the sense that they can both interfere with fertility, they can interfere with implantation, they can cause spotting. Polyps will almost never cause pain. Fibroids can if they're big enough or in a wrong place. Also, a polyp will never grow outside of the lining of the uterus, but a fibroid can grow all over in your pelvis, behind the bladder, near the bowel, in the sides. I've had fibroids grow into the perimetrial area, in the broad ligament, which is that like kind of tissue layer on top of the uterus. I've done some crazy laparoscopic procedures removing fibroids. So they can be kind of all over. You'll never see that from a polyp. Should they be removed before IVF, a polyp or a fibroid? Yes, if it's inside the cavity, 100% your polyps should be removed before your IVF. And the third part was, what was the third part?
For an embryo transfer after having polyps.
Yeah, same thing. For an embryo transfer IVF, that's really what I'm referring to is the embryo transfer. Your polyps or fibroids should be removed before your embryo transfer. You should never be doing an embryo transfer into a uterus that has a polyp or into a uterus that has a submucosal fibroid. That just makes zero sense whatsoever because they're easy to remove, guys. Super, super easy, especially polyps.
So just so you know, I can't answer this next question.
Oh, you can't answer this next question? Okay, good. All right, one that's definitely for me then.
Hello, Dr. V. What is androgen priming? Would you use it in low response patients prior to egg retrieval?
So androgen priming is the idea that if you take something like DHEA or testosterone, and usually we use testosterone for the quote-unquote priming, that it will improve the responsiveness of the ovary. So this is almost universally done in patients that have very poor ovarian reserve, are not yielding a lot of eggs. And for testosterone, there's actually 1 or 2 studies that show that it is beneficial. So we do actually use it in our patients when they have weaker ovaries. DHEA isn't really priming because you got to take it for 3 months. But you can use DHEA as well. It's essentially doing the same thing as the testosterone. Testosterone you use kind of right before the cycle, usually starting day 21 of the preceding cycle. DHEA for 3 months leading up. The big difference is there is 1 study I'm aware of that shows that testosterone improves live birth rates, whereas there are no studies that have ever demonstrated that DHEA improves live birth rates.
What things are tested in PGT? Can those things be tested during pregnancy, i.e. genetic testing during 10 to 13 week? Is autism tested in any of them, and differences between the two?
Okay, so let's go backwards. You cannot test for autism because we don't know what causes autism. So there is no testing of an embryo or even a fetus to determine if it's at risk for autism. So that one is easy to answer. PGT-A tests for chromosomal abnormalities where you have a rearrangement or a abnormal number of chromosomes. So for example, You want to make sure that your embryos do not have Down syndrome where there's an extra copy of chromosome 21. PGTA will do that. You want to make sure your embryo doesn't have a missing copy of chromosome 14. PGTA will do that. You want to make sure that your embryo doesn't have a segment within it that is damaged or abnormal. You may be able to do that with PGTA. If it's broken and flipped around, or it's switched over to another chromosome, you actually need something called PGT-SR. If you're looking for a single gene defect, so let's say you're a carrier for cystic fibrosis, your partner's a carrier. You don't want to have a baby with cystic fibrosis because that's a lifetime of trouble for that child. So for that, you need to have something called PGT-M, where they can actually look for that specific gene. But if you're just looking overall at chromosomes, how many, are they balanced, does everything look normal, that's PGTA. But it won't determine autism under any circumstances.
Hi doctor, I'm in IVF protocol with birth control, but 2 weeks of spotting. Is this normal?
Yeah, lots of patients will spot while they're on birth control. I'll normally ask you to go in and do your hormones because there are some people where the birth control is not working and they're going to break through bleed on it. So if that's the case, go get checked out.
What are your thoughts on autoimmune protocol? Essentially eliminating dairy, sugar, gluten, legumes, grains, nightshade veggies, etc.
Nightshade veggies. Okay, so that's not an autoimmune protocol, that's just being healthy. Autoimmune protocols involve things like steroids, heparin, intralipids, IVIG or subcutaneous IG, lit therapy. There's all sorts of stuff that we do to help patients. I am a believer, but only if you've proven to have failure in other circumstances, and then it actually can work quite well. We've got a patient right now that I just saw today. I'll probably post about her later on. She has had umpteen tries at success with multiple complications, and we finally got some therapy going for her, and she showed up with a very happy result today. So, you know, there is some benefit to doing this stuff. Even though a lot of people say it doesn't work, I actually do believe that it does, but very carefully selected cases. This is not something you do to everybody under all circumstances. This is something you do only when there's, you know, evidence for doing it.
What is duostim?
Okay, so duostim is something we found out about doing this show and reading constantly, where you end up doing a normal IVF cycle. So let's back up for a second. In a normal IVF cycle, we take advantage of your body's normal biology. So normally your eggs start to grow in your follicular phase, which is right after or during and after your period. The eggs start to grow. So we take advantage of that and we stim the growth of the eggs during that same phase, expecting them to grow and get to the point of ovulation like you would normally do in any menstrual cycle. So the problem with that is not all of the eggs grow at the same rate. And so what people believe now is that there are kind of what they call waves of follicular development. So you might have the first wave coming along and the eggs are growing, and then kind of a little bit behind it is a second wave. So if you're following that first wave, when it gets to the point where the eggs are mature, you need to make them release so you can do your IVF egg retrieval. You may still have a bunch of smaller ones that are in that second wave, which have not responded to the meds yet and have not started growing. So the question became, well, what if we immediately restart the meds for the IVF to get that second pool of eggs to grow? And the answer is that actually has been shown to result in better embryo quality and increased egg yield. And so duostim is essentially do one cycle of IVF like you normally would, wait 5 days, and then immediately start again on the stimulation meds to aim for getting more eggs. Does it work? We've actually had tremendously good success with it. I'm very pleased with the results. Does it work for everybody? No, nothing works for everybody. And that's why I always say there's no cookie cutter medicine in fertility. We're not baking cookies, we're making babies here. So It's not going to work for everyone, but for a lot of people, it can help. And because we recognize the difficulty that specific group of generally poor responder patients are having, we've discounted our DuoStim protocol so that the second cycle is much cheaper than doing the full repeat cycle. So you're actually saving quite a bit of money by doing 2 in a row. Keep in mind though, before we get kind of inundated with calls, we only do this for patients who are poor responders. It's not designed for people that are great responders because you'll actually get really bad hyperstimulation from that.
Hi, Dr. V. We sent 10 embryos for PGT testing. What % will be normal? Is there a way to estimate it?
Yeah, watch our Embryo Math video. So based on your age, it's on our YouTube channel. So based on your age, you can estimate. So I don't know what your age is, but if you are, let's say 30, you can estimate that probably around 30%. If you are 35, it's 50%. If you are 40, it's about 62, 63%. And if you are 43 and over, you're up into the 72 to 75 range. That's based on the study that's in our Embryo Math. Depending on which study you read, they'll vary a little bit in those numbers, but that's a very reasonable approach.
Hi, Doc. Kindly tell me if semen analysis of my partner vitality is 24% mortality, 40% morphology, 26% sperm count is 72. Is 72. Kindly tell me if it's all okay. We've been trying for 4 years now.
The vitality's low, and while you've given me a borderline motility score, I need the progression to know how fast they're swimming. That sounds like he's probably, and I'm totally guessing here, but that sounds like someone that's smoking. So if he's smoking, it will not work. The other thing that you would need for a sperm analysis like that is a sperm DNA fragmentation test, because it'll tell us how much damage there is to the DNA, and that's important.
Is Cryptozoothermia curable?
Curable, probably no, but it's treatable. So again, you got to do all those healthy things we talked about earlier in the show. Vitamins, weight loss, healthy diet, no smoking, no drinking, no drug use. All of those things are really important.
And the follow-up is, can acupuncture correct it?
No. It might help, but it's not going to correct it.
What is your next step after a failed FET with an untested embryo at the age of 28?
I'd probably just try again. So at 28, if you've tried and failed, the overwhelming likelihood is that the problem was your first embryo and that it just wasn't genetically normal. Now you're probably thinking, wait a minute, doc, that was my best embryo. Your best embryo does not necessarily reflect the fact that it was the best embryo genetically. It may have looked beautiful, but it doesn't mean that it's genetically normal. I have seen bucket loads of genetically abnormal AA quality embryos. And in fact, oftentimes I am firmly of the opinion that the best looking embryos are not the ones that are genetically normal. It's actually kind of the more average looking embryos that are genetically normal. So getting an amazing looking embryo does not mean anything. So if you're 28 and you have lots of embryos, and God willing you do, I would actually just try again one more time. If the second one didn't work, then we hit the brakes and we start investigating you and the whole process. So I always talk about 3 elements to an embryo transfer. There is the passenger, there is the passage, and there is the destination. So the passenger is the embryo. So number 1, almost always in a failed FET is going to be the embryo. The passage is our ability to transfer. Did they see clearly? Was there bleeding? Was there damage? Was there a long, sort of transfer protocol? Did they clean the mucus enough? Did they get a good view? Did it go in the right place? So on and so forth. The last place I worked with, the embryologist helped me do the transfers. He refused to put them where I wanted to. He would always go ahead of that. We did very well with our program, but we're actually doing even better than we did before because he just wouldn't put them in the right place no matter how much I said, don't put them there. So, now the embryologist I work with does exactly the right thing every time, and that's why our success rates are so high. So I think that you have to make sure the passage is done well. We've kind of really focused and honed our skills in doing transvaginal ultrasound guided embryo transfers for women where they have a retroverted, retroflexed uterus that's kind of upside down. Those are impossible to do without torturing the patient with the transabdominal ultrasound. But with the transvaginal, you can get a beautiful view without having to torture the patient at all. So those work very, very well, and we love doing those. So that's something I'll do frequently. The last part is the destination, which is obviously you. So you need to be checked for infection. You need to be checked for your immune system. You need to be checked for your vitamins, for your thyroid, for your hormones, for the quality of the lining. All of these things are really critically important. So remember, passenger, passage, and destination. Those are the things we look at.
Hi, Dr. V. What is your opinion on Menopur only cycles to help improve euploid rate? 38-year-old, AMH 2.5, 1/5 blast euploid after PGTA last cycle.
So there is no evidence whatsoever to suggest that Menopur only will improve your euploidy rate. In fact, there was a study not too long ago that demonstrated that even a natural IVF cycle with no meds had absolutely no difference in the euploid versus aneuploid rate to someone that got full meds. There is a study that I don't know if we reviewed now or not. I don't think we did. But there is a study that I used as the basis for our protocol that shows from the UK with a huge number of patients in it, that shows that the ratio of recombinant, so that would be like Recavel, Brevel, Gonal-F as examples, to urinary, which would be Menopur, and there are other products as well, we use Menopur, that the ratio should actually be 54% recombinant to 46% urinary. It's impossible to achieve that ratio. So we just use 50-50. So rather than actually using exclusively Menopur, you should actually mix a recombinant product with a urinary product. So in our program, we use Gonal-F and Menopur because I love both products and they're great. And in some instances, we use Recavel with Menopur and get also very, very good results. So don't do just Menopur. There is no reason to believe that's going to increase your euploid rate whatsoever, and not a shred of evidence to support that I'm aware of.
My partner's semen sample came back positive for a few white blood cells.
Yeah.
Could he be put on antibiotics? He has a history of taking antibiotics for white blood cells in previous samples. We are looking to start IVF shortly.
So you certainly can and should. He may need to be on them for a longer period of time. It can take a long time, especially if he's got a prostatic infection, to get rid of it. That usually requires a month of antibiotics. The other thing is that immature sperm can actually look like white blood cells. So make sure the right person is doing the semen analysis, because it may be immature sperm that they're looking at and not actually white blood cells.
With the example case mentioned with low AMH and 3 eggs, poor egg quality, would PGTA testing be recommended?
So if you get 3 embryos and your age is over 38, yes, I would. My embryologist and I were just debating this the other day. She feels that if you only have 1, the chances are high that you may damage the embryo in the process, and so that it shouldn't be done. I'm still trying to decide if I agree or not, but I defer to her expertise. I think that certainly if you're older, it's worth doing, especially if you have at least 2 or 3 embryos. If you are younger, it's definitely not worth doing. And if you only have 1 embryo or 2, I don't know, guys. I'm half-half on that one. I think that it's reasonable to consider. I don't know that it's indicated in every case, and it really adds a lot to the expense. I think you would have to ask yourself, what am I going to do with the information that I get? And by that, I mean, if you are forever going to be using your eggs only, it doesn't really make a difference whether or not they're normal or not. Just fire ahead and do it again. If you are willing to consider going to a donor and it would help you to make that decision knowing that your embryo was not normal, then yeah, you should do it because it'll give you the answer that you need to take that next step. So in some instances, it makes sense logically because it's part of the flow chart of decision making. In the other side of it, on the other side of the flow chart, so to speak, if you're always going to use yours and you're only making one, what difference does it make? If it's normal or it's not normal, you're not going to choose differently. So you may as well just put it in and see. Is way cheaper than having to do PGTA testing and will, either work or not work. And that way,
You have a bunch of questions to follow up with that, just so you know.
Okay.
I like this question here. So if the best looking eggs aren't necessarily the most genetically normal,
Right.
is embryo testing necessary? Can we implant 2 or 3 average looking embryos at 43 and AMH of 1 nanogram per mil?
So an AMH of 1 nanogram per mil is actually not unreasonable, especially at 43. That's actually pretty decent. If you have untested embryos at 43, you can definitely transfer 2, arguably 3, especially if they're day 3. Day 5, I'd be hesitant, but some people would actually say it's okay. Because we know that at 43, 72% of your embryos are genetically abnormal. So in theory, and the math doesn't work like, 72% if you had 10 embryos, 7.2 of them will be abnormal. But in theory, if you have 3 embryos, maybe one of them is going to be normal. So it's not unreasonable to put in 3. What you need to be prepared for is that this is not math, this is biology. And could you end up with triplets? Yes, you could. Is that a problem? Yes, it is. So there is a lot of concern and a lot of issues with this. And so it's not a simple process. You really have to be very, very careful and cautious about the whole process. So I would go through it carefully, but I'm totally comfortable transferring 2 untested. I'd probably be okay with 3 if you twisted my arm. Untested, you are taking a bit of a risk there.
How soon after giving birth can you try for IVF again?
If you mean try for IVF like a full new cycle, you want to breastfeed ideally for 6 months. Someone chastised me online for saying breast is best. You know what? I'm not going to bend to that one. So breast is best. And if you can breastfeed, you should. If you cannot, my heart goes out to you. We respect the fact that you cannot. And we don't demean anyone or disrespect anyone that cannot breastfeed. I get it. It's not possible for everybody, or it isn't for everybody. But if you can breastfeed, you should. So you should wait 6 months. If you're not breastfeeding, like 2-3 months later, you're probably good to go. In terms of embryo transfer, it's the exact same thing. Wait 6 months. If you are breastfeeding, if you are not breastfeeding, then you can pretty much do it a couple months later.
I'm 44. My AFC test saw 14 follicles.
Wow.
What do you think of protocol letrozole, 5 milligrams, Omnitrope, 33 milligrams, Metopure, 150 units, Follistim,
Yeah.
300 unit. How many retrievals suggest a 44 with AFC 14 for good embryos?
Okay, so first of all, you don't need letrozole in that protocol because you've already got a great antral follicle count. So that doesn't make sense. We usually use letrozole for poor responders. You're not a poor responder if you've got 14 eggs. The second part of that, I'm not sure why they're using Omnitrope and Follistim and Menopure. We don't have Omnitrope here, but that protocol doesn't make sense to me. So I'm not quite sure why they're using 3. We would normally use 2. And then finally, in terms of number, at 44, you need a lot of eggs. So watch our Embryo Math video. It literally walks you through step-by-step calculation of how to figure this out. It's a great video. It's like a full PowerPoint presentation on what to do. I built it for people like you who want the answer to this question. It's on our YouTube channel. Go to YouTube, type in DR Victory or Embryo Math. You'll see it right there. It's about 3/4 to the end where we talk about a 43-year-old as an example, and we actually do it twice so you can see the numbers. Bottom line is, I'll do some of the embryo math with you right now, okay? Let's say you get 10 mature eggs. So from your 10, if you're at a good center, they're going to get you 70% fertilized with ICSI. We do better, but let's just go with conservative numbers. So let's say they get you 7 fertilized with ICSI. From the 7, 4 will likely make it to blastocyst, again, 3 or 4, if you're at a very good center. So if you go from your 10 eggs to 7 embryos to 3 or 4 blastocysts, from those at 44, anticipate somewhere between 75 to 80% of them are not normal. So in theory, you may end up with 1 genetically normal embryo. You may end up with none. You need 3 genetically normal embryos to get a 95.2% success rate. So just going back to the math, you need 30 eggs to get there. Now, it doesn't work exactly like that, but that's kind of the very rough math of how to figure this out. So I would anticipate, in your case where you have 14, somewhere between 2 to 3 full cycles of IVF for you to just achieve 1 child. You may get more, but it's hit and miss, and you got to see how you do. One more? Is there like an army of you got it done? Holy cow, there's a lot of questions.
Whatever you call that.
Yeah.
Hey, so can you please explain what is moribund sperm prep?
Moribund sperm prep?
MORIBUND. Sperm prep.
I don't know. I've never heard of that before, but it sounds like a post-mortem sperm prep, which is where you take an electro ejaculation. It's a cattle prod. You cattle prod the guy's prostate, which even if he's dead will make him ejaculate. And then you can collect the sperm. Tarek's face. So you can make the guy ejaculate and then collect the sperm and still use it, because the sperm will live for a couple of days even if the dude is dead. So yeah, you can do that. We call that the Anna Nicole protocol because of Anna Nicole Smith, because that's basically what they did. So yeah, you can achieve success with that. I think that's what you're referring to. Obviously we don't do that, and there's a legal nightmare involved in that, but there is a way to do it.
Hi, Dr. Victory. Do you have any information about breast implants and potential impact on pregnancy, particularly recurrent miscarriage?
So breast implants or any kind of chest trauma can elevate your prolactin levels. And if your prolactin levels are high, it can interfere with your fertility. So you can go on Dostonex, which should suppress that effect, but that's the only time it would be a problem. Assuming you don't have a silicone leak. If you've got silicone implants and there's a leak, that can wreak havoc with your system and cause a lot of problems. So just make sure your implants are not silicone and or not leaking.
How do we reach you to set up consultations, and what?
Look at you again.
And what do you charge for consultation, and how long will you need to wait to get the consult?
When I mentioned electro-ejaculating the prostate, which has to be done transrectally, by the way, Tarek's eyes bugged out of his head, which is why I'm cracking up. Okay, so we charge $150 Canadian for our consults. For people that don't have OHIP. If you have OHIP or Canadian health insurance, it's free. Money is not really our be-all and end-all, so if you need help and you can't afford it, let me know and I will do my best to help you out. I don't really do this for money, honestly. I don't care about the money. So if you want to know how long, you just contact info, I-N-F-O, at drvictory.com. And usually the ladies will get you set up not too long. I don't think people are waiting for the info at Dr. Victory ones for more than like a month to 6 weeks. Don't quote me on that because the girls always get mad at me if I'm wrong, but they're usually getting you in fairly quickly. If there's an urgency, it's a cancer case, your age is much higher, let us know in your email. Say, hey, look, I'm desperate, it has to happen now. And the girls will appropriately triage that. My team is phenomenal. Whatever they feel they can do, they do. And sometimes they'll come to me and say, look, this patient's really desperate. Can you just squeeze in one more consult? And I'm a workaholic, so generally the answer is yes. Okay, one more and then we're done.
Okay, one more and we're done. One more.
The Tarek question.
I might be able to answer it, so you gotta watch out here. Okay. Alright, we'll go with this. Hello. You're great. What is your gut reaction to knowing IVF sperm is collected by testicular cancer diagnosis removal, sperm collected from testicle after diagnosis 1 week before removal? Feel hopeless.
Testicular cancer would not necessarily negatively impact your sperm. So as long as the sperm was functional at the time that they took it and froze it, it should be okay. So I wouldn't be concerned about that at all. As long as it was healthy sperm and it was good enough to freeze, it'll work when you thaw it. And the cancer won't impact the sperm necessarily. So that's a parenchymal issue with the testicle itself. It's not related to the sperm. There's no sperm cancers, so you should be okay.
More?
Oh, that was too easy, man. I got another minute.
Well, how about this? Can you explain assisted hatching on day 3?
Yes. So assisted hatching is a process where we laser hatch the shell of the embryo to facilitate the embryo hatching out of its shell when you want it to implant. There are 2 ways to do it. You can do it on day 3 or you can do it closer to day 5 or on day 5. So if you're doing PGT, you usually will do it on day 3 unless you have time-lapse embryo scopes in order to be able to know which ones are growing where and when, and then pick and choose. But they'll normally do it on day 3 so that by the time you get to day 5, the part that's becoming the placenta will extrude through the hatched component and you can laser it off and then send it for your PGTA. If you're doing it on day 5, you got to do it kind of early and then wait for it to extrude and then get your samples. So there are different ways to do it. And that's something you can talk to our embryologist about. Maybe I'll drag her on the show one day or talk to your embryologist about it. Or Tarek, because he thinks he has the answers to this.
So we got a question for the Dominican Republic.
Oh, wow. Dominican, hello.
Is it possible for a man with, again, the same Zoospermia can just have girls or boys? There are particular studies to sperm quality different to spermatogram. Regards from the Dominican Republic, and sorry for my bad English.
Hi, your English is, I think, okay. I got the gist of that. So the question is there a way or is there a specific abnormality in sperm that may make you only have girls or boys? None that I am aware of or have ever seen or heard of. And biologically, it actually doesn't make sense because your sperm are derived from existing cells, so they have to be split into girl and boy proportions. So not that I can think of or that would make any sense. Now, if there's a problem with one of your chromosomes, either the X or the Y, it's possible it could inactivate some of the sperm. So I guess theoretically it's possible, but I've never heard of it before. In terms of other tests for sperm, there's semen analysis and there's sperm DNA fragmentation. There are some people that are starting to look at infections in the sperm. You can do that through fertilization. And then there's also analysis of the genetic makeup of the sperm. That's also done through various companies. iGenomics is one of them that I know of. I've only done it once and I didn't find it helpful, but that is possible. Okay, guys, I have a phone call shortly with a patient, even though it's 9:15 at night here. So hello to the Dominican. Please send more of your sunshine our way. Stay safe. I hope you are safe from COVID there. Feel free to reach out to us. We're always willing to help. We are international, so we have clients in Japan, Israel, all through Europe. We're very busy in Europe, all through Canada and the US. So if you need us, we are happy to help you out. We're always here for you. And please, please, please don't hesitate. We're always willing to do our best to help everyone out there. Stay safe, guys. Have a great night. Exciting show. I hope you learned something. And if you have any questions, don't hesitate. Let us know. We'll be here for you next week. Take care.